other way than without doing everything in the beginning, and we are going to the sorry about it. So, in polytrauma and orthopedics, polytrauma and orthopedics, and also you want to know about early total care. Now we are going towards damage control orthopedics, and this is the way that we are managing all. Because when the patient is admitted to the initial part of injury with polytrauma, we manage initially with means of external fixators, splints or some traction, and when the patient is stable, we move for the definitive treatment. It is called early appropriate care, as Dr. Carnival mentioned in the earlier lectures. So spinal trauma, the concept of this spinal trauma management, it depends on how these patients are presenting, and it's a great challenge for the surgeons and difficulty prioritizing the cases over the spinal injury. So the concept of DCO and early appropriate care in the spine and prioritizing the patients, and in the emergency department it goes up to the operating room. So what are the concepts? Timing of surgery is important, when and what to do with the spinal trauma, and whether we have to go with the minimally invasive procedures or open procedures, and how are we going to give priority for the spinal injuries over non-orthopedics or orthopedic injuries. So the polytrauma, usually it is a blunt trauma. When it is open, then you know there is a bleeding, obviously then you can assess. As I told in the past, in the previous lectures, the patient's blunt trauma, you don't know what's happening, and even you can miss the spinal injuries, and the patient can deteriorate and we can lose the patient. And it compromises the patient's physiology, and it can damage the non-damaged organ also during the time of management if you don't address properly. And what are the concepts in spinal trauma management? As far as anesthesia is concerned, always is the difficulty we have to especially focus on the cervical injury. When there is a cervical injury, anesthesia takes more care once it is diagnosed. Usually when during the intubation, I am going to go in detail and intubation, and when you are putting the laryngoscope, and when you are mobilizing the cervical spine, it can damage more to the spinal cord if the patient is not having any spinal cord injury. So we have to take many care. In the meantime, you should not forget not to bring the pressure of the main artery pressure between 85-90 we have killed. If you bring it below that, it can cause spinal cord injury further. So these are the challenging cases. For example, with the ankylosing spondylitis, with the severe spinal deformities, is a challenge for the anesthetist as well as for the surgeon as well. So how do we time? Nearly all recently published data says early decompression and acute spinal cord injury should be avoided, and we have to stabilize early. So when is the early time? It is recommended to do before 24 hours. In that case, we can have 20% of recovery after 6 months. If there is done more than 24 hours, it's only 9%, even after 36 hours, it becomes diagnosed according to the American Academy publication. So exact time is remaining controversial, but still we have to, if the patient is stable, if the patient is not having any other injuries, we have to do as ready as possible and decompress and stabilize the spine. So how are you going to stabilize the patient? There are ways of surgeries, and also with minimally invasive procedures are available. So open surgery has some disadvantages of blood loss and also causing infections and tissue damages, but it has advantages of doing the fusion. We can put bone grafts and But percutaneous screw fixation or minimal invasive screw fixation, we can stabilize without blood loss and without causing infection, and it has a risk of exposing more to the radiation. When it is stable to the patient can be mobilized and sent home early. So these are the cases. One of my cases, the patient was set up, but we have the casualty and 48 hours after we have the theatre. So these patients were operated within 48 hours in our unit. So they are sent home early. Nowadays, we won't see any patients having long-term interactions or long-term bed rest with the spinal injuries in our setup. So how are we doing with the minimal invasive or open surgery is depending on the surgeon's preference. Open surgery, as I told you before, we have enough advantages of doing the fusion, but minimal invasive procedure needs some expert training as well as the commitment of the surgeon. So there's another way, those days you know that we are with bed fractures, we were managing conservatively, keeping the patient in bed rest for 6 weeks or even more than that. So nowadays there's available possibility to minimal invasive. We can put bone cement into the affected vertebra, and this is the post-op image, and the patient can start walking from the theatre to bone. So that's the advantage. If you are not doing, some patients may end up this type of collapse and it can disable the patient's spine. So how are you going to prioritize this surgical plan? So life-threatening injuries have to be given priority. It's obvious, or in thoracic injury, so abdominal blood traumas, the patient is not stable. So generally, all these traumas centers, level 1 trauma centers, dual surgeon approach is done. So 2 surgeons operate at the same time to reduce the time of surgery. So this one everyone knows that according to ATLS program, we assess the patient whether it is stable or not. If the patient is not stable, then you go for damage control orthopedics, apply external fixators, splinting, and later you can go for the surgery. If the patient is stable, if the patient is neurologically intact, then we can go for the early total. Yeah? Or if the patient is having neurological deficit, we can go for open surgery and stabilize. Borderline cases can be considered for minimal invasive procedures or open surgery depending on the patient's stability. So there is a concept of continuous or non-continuous procedures and fractures. That is, when there are 2 fractures in the spine, what to do? There is a research article, it says when there are less than 5 segments in between 2 fractures, it has to be fixed as a single structure using spinal fusion rods. And when it is more than 5, it has to be separated, it has to be fixed separately. And you must know in cervical and lumbar spine, we have to keep mobility as far as possible. In thoracic spine, we can stabilize the long segment of thorax. It's not a problem because it's a less mobile segment in the spine. So this is one of the examples of 2 fractures involved, and it is fixed with 1 segment of fixation using screws and rods. And this other one I downloaded from the internet. Actually, here you can see there are 2 fractures between T1 and L4. It has to be fixed as a single, but it was fixed in 2 separate structures. And managing the operating hemodynamic stability in the patients of spinal management is important. So pre-op planning and how much of blood we have to preserve, communicate with the anesthetist, and cell saver may be useful in some conditions, and tranexamic acid is useful drug in the management of blood loss, and they can be given as a single dose or infusion, and reverse lateral position with hip bolsters, it helps to reduce the abdominal pressure and reduces the abdominal pressure during the surgery of spinal fixation. And what's the role of surgeon during the intraoperative management? Meticulous dissection and identify the bleeders from the muscles and ligaments, and especially from the extradural venous plexus. When you start bleeding, it's very difficult to control. And we have to use monopolar or bipolar rotary, and bone bleeding can be managed with the bone wax, and there are synthetic materials available, thrombin, collagen, and gelatin, cellulose materials with different trade names are available to use. And most of the considerations, there was a stage. It was recommended to use high dose of steroids, but it is not recommended nowadays, and it is not practiced most of the places. And thromboprophylaxis, it is a balance between the bleeding as well as the thrombosis. We have to plan what we want to do. When the patient is considered to be bleeding, we can use mechanical means, and early spinal stabilization and mobilization is considered. In summary, primary and secondary surgery with appropriate spinal precautions to be done, resuscitate patient with spinal cord injury and maintain the cord perfusion with satisfactory mean arterial pressure, and close reduction. Inline reduction has to be considered when the patient is unstable until the patient is stabilized, and multidisciplinary action has to be propagated, and percutaneous fixation is considered as safer and with a better outcome. And anesthesia has to be very careful when you are manipulating the cervical spine patient, and stable spinal fixation incorporating 2 fractures. If it is less than 5 cm in between, it has to be incorporated with 1 system.